Good afternoon, everyone. Can I request you to scan the QR code and fill it out? You're part of an experiment, not really. This is a slightly novel experiment, so would you please fill in the questionnaire if you scan the QR code and flash the QR code at the end of the session so that you fill it out after as well, just to see whether the talk has any relevance to your life and to see whether it makes any positive impact. Thank you.
Good evening to all of you. On behalf of Chairman Divecha Center for Climate Change, I heartily welcome you all for this wonderful seminar. This thought-provoking seminar is being organized by Professor Dr. H. Paramesh. Sir is very active in organizing many such seminars, at least one per month. He is using, Professor Dr. Ramesh is using his wide contacts for the benefit of all of us and rather well-being for all of us. Today, he has chosen such a wonderful topic, which really requires, as we see in the media these days, such things, unfortunate things are happening. And I'm pretty sure, as Dr. Aditya just now said, I would like to repeat again that all of you please scan the QR code, share your thoughts. That will not only be beneficial to you, me and all, but also to the Manasa group people, wherein they would like to try to improve themselves upon how to deliver. So thank you very, very much. I now request Professor Dr. Paramesh to take over the stage.
Thank you, Srinivasan, for your kind words. Good afternoon, everybody, faculty members, students, and invitees. This month, the World Suicide Prevention Month. That's what every month we have been organizing for over 3 years. And for this fun, this is organized by the Divecha Center Climate Change Institute of Science, Lakeside Education Trust, International Pediatric Association situated in Geneva. So with the permission, we like to record it, sir. We like to send it to Geneva. It will be all over YouTube with your permission. Now, in the absence of our chairman, Satish, we have with J. Srinivasan. He is the founder of this institute. And he's a man encourages the academics. No, unbelievable. Encourages everybody. And it's a pleasure to work with him anytime. Any question you learn, we'll ask about it. Physics, we doctor don't know much of mathematics and physics. I have to learn few things from basic things from him. Now, in addition to that, he's a man practices what he preaches. And everybody has to control 20 tons of carbon footprint of the global warming. He walks from Malleshwaram to here, go back in walking only. And also pure vegetarian food has got less carbon footprint than to non-vegetarian. This is what he's been doing it. This is a great thing. And we have a great opportunity having him here. And now he is the distinguished professor working here in the atmospheric science, oceanic science. And his uncle was none other than Nobel laureate Sir C.V. Raman. And he has got the same aptitude like that, and he don't show off anything like that. Foot on the ground, that's a great thing. So I request him officially invite everybody. Over to you, sir.
Good afternoon. Welcome you all to the monthly seminar that
Dr. Parmesh organized for the last 3 years. We have covered many topics about heart, about our intestine and various things. But today, there's a topic which is a taboo in this society. Nobody wants to talk about it. And in my younger days, it was partly because of family honor. You don't want to talk about something like that. So it's good that the discussion, it's good that people hear about it, because whenever I talk about climate change to diverse young audience, there is a new phenomena called climate anxiety. Whenever I keep telling them about terrible things that will happen in the future, people get more anxious. So it's high time we hear from specialists about these issues and how to deal with your anxiety so that you avoid such unfortunate occurrence. So I request Dr. Paramesh to introduce the speaker.
So I will first introduce the chairman. He will introduce the speaker. Dr. S. Kalyana Sundaram. He is did his MBBS in Madras University, MD Psychiatry in NIMHANS, Bangalore, 1975. He was a faculty there, and also he was a professor of psychiatry, principal RF Ajay College, and involved in a psychiatric rehabilitation over 3 decades. And he's got several awards and also publication, international and national textbook he contributed. But more than that, as I know him since 1981, we were together in Lakeside, and he's a man with action, dedication, and upright man. He don't want to hesitate anything. We love that one very much. In addition to that, he's a passionate golfer. So KGA, he plays anything like that. It's a great honor to you, sir, to welcome you as the chairman and moderate the topic. Introduce each other. Come over, please.
Thank you, Dr. Paramesh. Yes, 1981, I quit NIMHANS because the government salary at that time was so abominably low, we could make ends meet. So I joined private practice, and a place that was open to many of us at that time was Lakeside Hospital in Ulster, which Paramesh started, and we became colleagues and friends over 40 plus years now. May I ask all of you to come forward, because they're like a typical classroom. The first 3 rows are empty, the back rows are covered, and then people stand behind the door. Please come forward. I've been a teacher for 50 plus years. The pattern is not changed. Let me first introduce Dr. Aditya Subramaniam and briefly about the topic what we are discussing today. When asked about his introduction, he has given about 1.25 line, but it's much more than that. Aditya Subramaniam hails from Bangalore, and he did his medicine in KIMS, went on to do his psychiatric training in UK, has been a consultant psychiatrist in Edinburgh for 25 years, and he has come back to run his private nursing home, which is Manasa Neuropsychiatric Hospital in Jayanagar First Block, Ashoka Pillar Road. The important thing about that is father, Dr. H.S. Subramaniam, which Dr. Paramesh told me was his teacher briefly at one time, was the first person to have started private psychiatric hospital in Bangalore, if not in Karnataka. And very astute clinician, passionate about research. In UK, he got an MD degree, which is a research degree, not a degree which you study. And then, of course, he's an FRCP. And I have known him from the time I was pretty young. And when I decided to leave Richmond Fellowship to the CEO position after being I've been with the fellowship for 36 years, which is a Center for Psychiatric Rehabilitation. Maybe one of these days, Paramesh might want to organize a program on interactive session on what is psychiatric rehabilitation, what is chronic mental illness, what is depression,
Most people think they know, but they don't. And he's currently the CEO of Richmond Fellowship Society. When Paramesh asked me whether I will give a talk, I said, no, I'm not one of those cut and paste speakers. I would prefer somebody who has worked on this topic. Dr. Aditya Subramaniam used to run a program in UK on suicide prevention issues. So he has got hands-on experience. This morning when you open the paper, the first thing that strikes you is tragedy. Lady, 31-year-old, jumped from a building somewhere in Bangalore because it was what is called dowry harassment. There are stories galore, sensational, and in the newspaper and the media. But what we want to understand is, how do we recognize this? How do we recognize a person is suicidal? Does he or she leave telltale signs with the family, with the doctors? 50% of them have, before committing suicide, have met a health specialist. What happened between that and the end? More people attempt suicide than you can see die in accidents. So there is a lot of work on suicidology. I don't understand between you and Dr. Aditya. Dr. Aditya is going to elaborate on all of these issues. He's going to talk about, we have the highest number of suicides in the world. Every 40 seconds or something like that, somebody dies across the globe. Very rightly I said, mental health professionals, including mental health professionals, are not trained in helping suicidal people. And how do we go about identifying early signs? How do we help? And remember, he also mentioned somewhere about quota. Any high-powered institution, including Indian Institute of Science, is not free from this kind of a tragedy. Why does it happen? How do we manage? Dr. Aditya Subramaniam, please. Thank you.
Thank you, Dr. KS, and Professor Srinivasan, Professor Paramesh, thank you for inviting me. This is a hallowed ground indeed. I'm not sure I deserve to stand here, but thank you to Dr. KS for that introduction. And hi to everyone. So this is a bit of an experiment because I'm used to doing this talk for mental health professionals, and a lot of you are not mental health professionals, which I'm very happy about, because I think otherwise you sit in an echo chamber. And I think those of you working in climate science will know what I mean when we talk about an echo chamber, because you're talking to a small number of converted people. A lot of suicide research is complex, and I think riven with problems with the data and their analysis. So although I've very happily said India has the highest number of suicides in the world, the truth is we really don't know how many there are, and also how we compare with other countries that game their data, like China, for example. India and China are both gaming their data continuously, but I imagine, again, in the climate world, that's not unusual for you. So this was the title of the talk, and I'm associated with a lot of organizations, and I ran a suicide prevention service in the UK for 15 years. And one of the big questions for us in India is what works? What, if India's suicide rates are so high, what would actually help us effectively reduce the suicide rates? There are a few mental health professionals in the room. Thank you for coming. The truth is there is no evidence that mental health professionals reduce suicide rates. And that's an important fact. That actually what we may need is more public health interventions. We may actually need governmental interventions. In fact, the most successful interventions to reduce suicide are usually governmental policy level changes about the availability of poison, for example, and we'll talk about it. So what I'm hoping is in the next 30 minutes to see if I can change your mind about how to help someone who might be feeling even transiently suicidal. That might include you, a loved one, a family member, a friend, or somebody else that you work with. And let's see if we can make a change in that in the next 30 minutes. It's an ambitious thought. I might fail big, but why not try? So for those of you who have not scanned the QR code, please do, because I was trying to do a before and after assessment. Please do scan the QR code and fill it in. It'll take you about 60 seconds. Let's see. If you don't like it, please blame Dr. KS. So this is my basic premise. All of us know that if you have chest pain, you need to get yourself to somebody who might help you. Sometimes people sit on the chest pain thinking it's the indigestion, gas trouble, this, that, something else. But most people know generally, if there's chest pain, you should get yourself to some help. But almost no one knows what to do when we meet someone who's feeling like life is not worth living. And I'm really hoping that we can change that, because I think that's just a very simple matter. Dealing with that would be an easy bit. Finding an effective way to help that person is a bigger challenge. So there's something called zero suicide. I think climate scientists and us have something in common. I think you have discovered that you're trying to save the human race from itself. And of all the great apes, we are not the greatest. We're probably the most toxic hominid that has ever existed. And let's face it, if you're really honest, you'll recognize that the best thing for the Earth is probably the extinction of the human race, because we're not going to achieve 2.5 degrees, are we? We're struggling, and you're struggling to change human behavior. And in the same way, we in mental health are trying to save people from themselves. And we are trying to adopt this approach, which is quite radical, to see, can we reduce suicide rates to zero? And this is an American approach, as you might imagine, from the most ambitious ones. But it might actually have some sense behind it, because we're treating cardiac events like this. We're treating strokes like this. We say, can we reduce as close to zero as possible these events? Let's see. So what I'm going to try, and I'm going to use the word teach, if you'll forgive me. 3 very simple principles of how to help someone who is feeling that life is not worth living. And as I said, that might be you, or a loved one, or someone you care about. So you assess, you intervene, and then you maintain the intervention so that you can help that person get past that crisis and get to help and live another day. Very simple. There's very little here that is, if there's any jargon here, if there's anything that's not easy to understand, that's my fault, because it shouldn't be complex. It's actually surprisingly simple. So I have a question for some of you. What would make you wonder whether someone is suicidal? Please use your imagination. Guess. Feel free to shout. What might you think, sir?
Abnormal behavior.
Abnormal behavior. Thank you, sir. Abnormal behavior, and kind of what? What are you thinking?
I mean, not related to the environment, particular environment where he lives. So,
Thank you. So sometimes people who you know well don't look like their normal self, and they're not their usual selves. So something is different. That would be a good clue.
easily we can distinguish.
That would be one. Anything else? So some people isolate themselves, and that's a very common symptom of depression, where people don't want to be with others and prefer to be with themselves. So that would be a good one. Come on. What else? If you're lucky, they will look different. And this matters because a lot of families, in my line of work, I sometimes wonder whether we truly know each other, because whether we truly know, can we spot when someone is different? If you're close to someone, you're more likely to spot them. Something's different. They're not talking as much. They're not smiling as much. Sometimes they're a bit more irritable. Sometimes they're not as productive. They're not as involved. There are a variety of things. So there's a whole list of things. And these are not rocket science. These are very simple things that we see in mental health, but actually we see in daily life all the time. Now, one of the things that you'll notice is each of these things are by themselves almost ubiquitous. They're so common that they're not specifically a kind of a warning sign. But taken together, when you see more than 2 or 3 together, then it's worth starting to think, is there something wrong here? Is there something we can ask about? Is there something the person needs help with? So please pay some attention to this. And I think there is a general sense of embarrassment in us when we see someone who is different, who's not doing okay. We don't tend to ask, are you okay? Because we worry that, look, it's we're crossing into somebody's personal space. It's none of our business. Maybe they're having a bad day. But if there's one thing I would change in you today, that would be it. And actually, the National Rail in the UK has had a fantastic program. They have a huge rail network, nowhere near as big as India's rail network, but they have a system where they have taught all their employees to ask one question. If they see someone who's not looking okay, that employee has been instructed to go and ask a very simple question: are you okay? It's such a simple question. And by doing that, they have reduced the suicide rates in the National Rail Network. As you might imagine, train lines across the world are very attractive to people who want to end their lives, including India. And so it is in the UK, where people choose to end their lives on a rail network, on a rail line, on a bridge. And it's a very important question. So my suggestion to you, even in a busy city like Bangalore, if you see someone who's not looking okay, particularly in the IISc, please ask that question. What's the worst thing that can happen? I'll tell you to go away. But please ask. So that's my first request to you. Ask. Asking explicitly whether somebody, and if you're seeing somebody that you know, and if they're talking about not feeling okay, it is okay to ask. And I will teach you the question to ask. I promise you, it's not tough and it's not scary. But there's generally a misconception, even among doctors, that if you ask such a difficult question, that you might plant an idea into the head of a vulnerable person that was not there before. And I promise you, you will not. You will not cause harm by asking about suicidal thoughts, plans, or intent. I promise you. Then we'll talk about what the risk factors might be and then how you might intervene. So, asking explicitly. These are the kind of questions we ask. Now, these are all in English. Now, we all speak a variety of languages, very easy to translate. So this one is a well-validated way of asking questions, but please feel free to ask the question in another way if you wish. So the first question, which I often ask is, have you wished that you were dead, or wished that you could go to sleep and not wake up? And this is sometimes something that we would call a passive death wish. A lot of us have gone through this, let's be honest. I've gone through it, particularly before an exam that I'm not prepared for. I remember thinking, wouldn't it be wonderful if I didn't wake up tomorrow? Or something else happened. National band or something. But this kind of a passive death wish is very common. So I don't want you to freak out if you had these thoughts. Many of us had more intrusive thoughts. So the first question is a kind of a gentle entry into this. And sometimes we ask this question in different ways. Do you ever find life not worth living? Do you ever get to that point where you think life is too hard? So you may choose different ways into this, but this is the kind of question you're really asking. And then you ask the other question, have you ever thought of finding a way? And this is an American questionnaire, which is why they're very direct and say, have you thought of killing yourself? You might want to say ending your life. You might want to use euphemisms, but be careful that you're not so euphemistic that you miss the point. And if the answer is yes, then you go on to the rest. I'm not going to read out all the questions, but really you see where this is going. Have you been thinking about it? Have you been thinking about it? Have you been researching it? Have you Googled it? And sometimes the other question that you might ask is, okay, so you've had these thoughts. How far have you taken the thoughts? What are you thinking? Are these just thoughts that you have? Do you have you had any thoughts of what you might do, whether you might act on them? So these are thoughts, there are plans, and then there is intention. Have you worked out, question number 5 is a very serious question. Have you started to work out the details of what you might do? And then whether or not the answer to question 2 was yes or no, you would ask question 6, because you want to know whether there's a lifetime history. One of my very good friends died by suicide last year. For all of my life, I'd noticed that he'd had a scar on the left side of his wrist. As a doctor, you'd think there are not many ways you come by that scar. And as a psychiatrist, I thought, that looks like a self-harm scar. And I'd even asked him once, I think, and he'd said, oh, surgery agittu. And it looked like a laceration. And he died by suicide. He was around my age, slightly younger, and he'd had marital troubles. And middle-aged men like me, marital troubles, unemployment, financial difficulties are a very, very common precipitating event for suicide. And suicide is a very common cause of death for people my age. And in his case, he'd had marital difficulties and financial difficulties, and he died by suicide. And only the week before his death that he'd reach out for some help. And I tried and failed to help him and his wife because they were having a very acrimonious time of it. And I had not appreciated that he'd had that wrist injury was actually a suicide attempt at age 16. Had I known that, it would have really helped me understand the risks better, because there were no suicidal thoughts, plans, or actions voiced at the time of his suicide. I want you to look at the fact that there are colors associated with a low risk, moderate risk, and high risk. And I'm going to hopefully convince you that suicide risk cannot reliably be measured. There are no scales in the world that have been shown to have even remotely useful validity. Face validity, yes. Construct validity, maybe. Otherwise, they are mostly invalid. One of the most problematic areas of my work is that a lot of my mental health professional colleagues have been taught to use suicide risk rating scales. As if you did this rating scale, then you can work out, is this person low risk, medium risk, or high risk? I want you to stop thinking of low risk, medium risk, high risk. When Dr. Paramesh sees a patient with chest pain, I'm pretty sure he doesn't waste his time thinking, is this low risk, medium risk, or high risk? I think he will think, okay, this person needs investigation for the causes of chest pain. So it is with suicide risk. 75% of people who die by suicide every year would have been thought in the week of their death to be low risk or medium risk. That tells you, I'm trying to find the right technical word to describe these scales, how crap these scales are. Please don't use these scales, particularly if you're a mental health professional, if you're a counselor in an institution, please don't use these scales. They will give you a false sense of certainty. That's one of the problems with these, that it's not only not useful, but they're actively harmful in the management of suicide risk. So all I want you to do is, if question number 1 comes yes, then you follow the rest up. But question number 1, I would accept in a lot of my patients, and I don't know if Dr. Kayes would agree, a lot of my patients, particularly in depression, anxiety, will say, yes, sometimes I don't want to wake up in the morning, but otherwise I'm okay, I'm not going to do anything. Those are not people I would actively worry about, because there are a huge number of those people in the city, and the area under the curve would be too large if we intervened at that level. But for the rest, anyone who answers any question from 2 onwards, please think of them at risk. Please don't use the words low risk, medium risk, high risk, because to be fair, we simply don't know the meaning of those words in suicide risk. My brother's a cardiac surgeon, and I'm sure he can tell you that if you do an angioplasty or you do whatever else, you can sometimes identify people who look like they're at higher risk, but no one can tell you what that risk really means with respect to survival. So please don't use those terms anymore, particularly those of you who are mental health professionals. This is step 2. In addition to asking these questions, we will look for these factors. Those of you, whether you're mental health or not, I urge you to look out this paper, because for 2 reasons. It's a fantastic paper. Lancet Psychiatry is doing some good work in publishing South Asian data. And the authors are excellent researchers. Lakshmi Vijay Kumar from Chennai, Prabha Chandra, I think from NIMHANS, who's not really a suicide researcher in general, but she's done some good work here. And Soumitra Pathare from Pune in Maharashtra is doing amazing work. So really good work. There is an older paper by Vikram Patel et al. About the million deaths study. So those are worth looking at. One of my very good friends, Murad Khan, Professor Murad Khan from Aga Khan University in Pakistan, is doing some amazing work in South Asia. But when you look at this graph, I'm not going to go through all of it. You will see that some of it is very intuitive. What are risk factors for suicide? Things that pain you, things that hurt you. You're sitting in an academic institution, so you will automatically look to the educational stresses. Some of you doing your PhDs will realize that I think doing a PhD is an independent risk factor for having thoughts that mean sometimes you don't want to wake up in the morning. I'm currently treating 3 people doing their PhDs. And for each of them, they all have high standards. And I have to confess to them that it took me 9 years to finish my doctorate in medicine, because I was a really lazy student and terrible with the data. but there are obvious and some unusual risk factors. I'll let you look at that. Please look at that paper. It's a really excellent paper that I really recommend. There are specific risk factors in India. India is particularly toxic in some ways. Although we are very proud of our culture, and I'm sure we have good reason for it, there are special circumstances in India, Pakistan, Nepal, Bangladesh, Sri Lanka, in South Asia, in the 7 countries that we are. There are very particular risk factors that I urge you to look at. We really don't understand how to measure caste discrimination, stigmatization. These are things that are really complex, and I'm not convinced that the social science experts have been able to work with statisticians in a way that help us understand the size of the effect of these. This I wanted you to see. In most countries in the world, marriage protects the mental health of the newly married, not in our country. Being young and being married not of your own accord or not of your own consent is a very high risk of suicide. So one of the things we're hoping to do is to try and work with young people to say, can we help people say no to marrying against their will? Is that too simplistic? It may involve disrupting some of our cultural boundaries, but maybe that's what we need to do. So in India, we're quite particular about this, that young women, marriage seems to protect the mental health of men. It does not protect the mental health of women. So it's not always clear to me why young women want to marry, other than social pressure. Don't quote me about this at home. And there are protective factors. Being Muslim in a Muslim majority country is protective against suicide to some extent, not absolutely. It's not clear that being Muslim in a Muslim minority country will protect you. It is not very clear that Hinduism protects against suicide. In some religions, for example, in Jainism, there are accepted forms of suicide like salekha. I think in Jainism there is another word that I can't remember. Does anyone else remember it? One of the words for it is salekha. Those of you like reading, there's a really nice book by William Dalrymple called 9 Lives. The very first book, story is about a woman who dies by salekha. It's a socially accepted way of dying in Jainism. Once you identify that somebody is at risk, whether that's you or a loved one, and you've asked the questions and realize that they are at risk, don't ignore it. We're going to ask you to do something called a safety plan. Very simple. And in fact, I'd emailed someone, I hadn't followed it out. Apologies, normally I would have a handout for you to have, but if you email me, I will share with you a safety plan, or you can Google it and you'll find it. I'll show you it in a minute. And doing a safety plan is associated with lowering the risk. What I don't know is how effective it is in India. And one of the things we're hoping to find out is what are the interventions in a country like India that are clinically effective. Because the suicide is such a rare event, a relatively rare event, it's very hard to know the effectiveness of small-scale interventions. It will have to be a national intervention that I think will need to be with a lot of data linkage. We'll see. So, safety plan. Very simple. How does somebody recognize that they're not okay? And what do they normally do? What can they normally do to make themselves feel better? Now, I thought this was a fairly straightforward thing, but actually you realize when I see patients in my clinic, and I don't know if the same is true, Dr. K.S., when you ask people, what do you do when you're feeling crap, when you're feeling low, when you're feeling sad? I'm amazed at the number of people who can't tell me. I think that's partly because we're all focused on our education. We're very good at passing our exams. You guys must be fantastic at passing your exams. Look at where you're sitting. But are you also very good at identifying your emotions? Are you also very good at saying, when I'm feeling crap, I want to go for a walk, I need to go for a run? These are the things. I also ask the reverse question, what do you do for fun? And the number of academics who can't tell me is quite scary. At any age, I've met people who are professors at 50 who don't know what to do for fun. They will say silly things like work is very enjoyable, which is, what is that other technical word? Bull. So ask people what they can do for fun that might make them feel better. Try and identify people that you can actually get in touch with who are fun to be with. Now, you know who I mean, fair weather friends. You know the kind of people you want to go for a coffee or a drink with, ideally not an alcoholic drink when it comes to suicide, because that increases risk. A non-alcoholic drink, no intoxicating substances. Those people who you can actually go to, who you don't have to talk about your difficulties to. You know, there are a lot of friends that we have that you can't really talk about difficulties with. These are fair weather friends. Go there, you have a good time, come back. Identify those people, because that may be something that will help you. And the next thing we ask you is to identify people who you can get in touch with, who can actually help you through a crisis. So in my case, it's very clear, it's my brother. No question. I don't think he knows. I'll tell him about this, by the way, which is whenever I'm in trouble, I phone my brother, and he always helps. And you will have someone like this in your life. And Dr. K.S. will know, sometimes we meet people who struggle to identify someone like this. When you're depressed, it's quite hard to believe that anyone cares about you. But the truth is there will always be someone who cares about you. Perhaps not to the extent that you would like, but you will know. So if I were to redo the education system, for which I have very little respect, it would be that we would teach younger people that the most important thing is relationships. It isn't how good you are in your exams. You know, it really isn't. And you'll know this to be true. All of you got into fantastic degrees and you're doing it, but you remember how long the feeling of happiness in older age is the quality and the number of your relationships, not how much money you, not the impact factors that you had, not your citation list. None of those things reduce, none of those things promote quality of life. Forgive me for saying it in this environment, but that's the truth. It's very important that if you have friends or family who are suffering, that you get in touch with their family urgently. Do not spend too much time trying to single-handedly keep someone well and alive. Very hard to do. Don't do it. Whether you're a mental health professional or not, doesn't matter. They may feel that talking to family will not help. But I want you to think of it in another way, which is they may be right, but if they're living with their family and they're being supported by their family, who else is there? Number one. Number two, if you don't speak to their family, then what is your plan then? That you're going to single-handedly get them through this crisis? No, don't do it, because that's not worth it. You may be surprised, families who are really rubbish at minor things sometimes rally around when they realize that things are really difficult. Occasionally, your friends may be right that their family were rubbish at supporting them, but at least you tried. And I think it's really important you do this. Contacting a mental health professional. Now, who do you contact? Now, this is a tough one because there are helplines in Bangalore. There must be, I don't know how many. You Google it, and each year I see the SEO is changing, and there's a high, and there is different helplines. It is clear that helplines save lives. You know, this is an evidence-free zone. Now, helplines will say that we were able to help so many people, but how do you measure the size of that effect? Yesterday, I went somewhere to an organization where they are running a helpline, and they said, oh, we had someone who thanked us a lot for speaking to them last week. But what does that really mean? We don't know. So the helplines worry me because I don't know who runs the helplines and what they've been taught. The average health professional is not qualified to help you through an episode of suicidal thinking. So Googling the nearest counselor, the nearest therapist may be the right thing to do, but may not be sufficient. Most psychologists are not taught to manage the acutely suicidal. Most therapists are not taught. Most psychiatrists are, and there are not that many psychiatrists. So there is an issue in India. So one of the reasons I'm doing this talk is to hope that we're going to do a trial of seeing whether we can just train interested people in helping the suicidal. Because why do you really need a mental health degree to do this kind of work? Like heart health, I think there is a lot of community education that might make a difference. But again,
I'm not sure of it because the evidence is lacking. The last one sounds like a silly thing. But one of my colleagues from Edinburgh, Professor Michael Ediston, did his PhD and his doctoral work in Sri Lanka, where his success, and it was extraordinary. He's not a psychiatrist, he's an emergency care physician. All he did was speak to the Sri Lankan government and the pesticide manufacturers in Sri Lanka and said, why do your pesticides have to be so lethal to human beings? We know they need to be lethal to the pests, but do they have to be so lethal to humans? And so the companies have reduced the human lethality of the chemicals they have. He's worked with a series of villages that have agreed to keep all the chemicals in a safe place outside of the village with limited access. And he has helped the local primary healthcare service cope with these suicide attempts with specific pesticide-related antidotes. Very simple thing. So you would think that, if someone really wanted to die by suicide, nothing would stop them. That's not true. Just putting away some of the things that they might be thinking of using makes a huge difference. So sometimes Dr. Kess knows what I mean. When we send someone home, we might say to the families, take away all the knives and put them in a safe place, or take away all their medicines and put it in a safe place so that they don't use that in a suicide attempt. These things matter, and there is good evidence for this, by the way. One of the few things for which there is controvertible evidence. This, if you want to Google it, is a safety plan. This is what we do in Manasa. We have a more elaborate one, but it's a very simple thing. You Google it. This is the Stanley Brown one. There are a variety ones. I'm not marketing the Stanley Brown one. They're free. It's online. You can find a PDF. If I had my way, I'd have been giving each one of you one today and asking you to complete one for yourself. Please Google it. And if you can't, then just email one of us and we will share a copy to you. This is such a simple thing. And Amoga, our research psychologist, is here. We're still doing it with all our patients in Manasa. When they come, I ask for a safety plan for them so that before they go home, they can take one. And if the risk is very high, then we try and keep them for a short time to help them through their crises. Use families to help you. Sometimes you will meet a friend who doesn't like their family, doesn't get on with the family, and part of the problem might be the family. But I'm just reiterating this to make this point. I'm hammering on the point now. This is don't work alone, because if you're working with someone who's suicidal, if it's not you, if it's you, then go and find your family and your friends and tell them and speak to them. I have very rarely met families who are really bad at managing this kind of a problem. Families do care. Once they know how serious something is, they do care. A very simple example of somebody I've been seeing. This is a businessman whose companies you will see all around Bangalore, very successful man in his 30s, going through a divorce. His warning signs are very clear. He has very posh cars, lots of Porsches and Range Rovers and stuff. He likes to go into his car, go for long drives, and as is sensible in Bangalore, you'll find tekas on the highway. Stops in a teka, buys lots of alcohol, some drugs, takes them, and drives further. And with a kind of belief that at some point he will crash into something and kill him. The things that he finds useful from a distress point of view is going to the gym. He says going to work help him. I'm not sure I believe him. There are good fair weather friends that he can hang out with, including a cousin. And then there are people. He has an uncle who's a surgeon who's very sensible, and he calls him when he's in trouble. He likes his sister and he contacts them. When he's in real trouble, he gets in touch with me. And in this case, simple things like making sure that he gets a driver and he doesn't drive himself anywhere, that he avoids bars, that he has friends who don't drink. We're using a drug called disulfiram that makes you allergic to alcohol, and that's something you can take. And in this case, and it's not magic. Dr. K.S. knows this is a very ancient drug that a lot of people don't use anymore. But in his case, it's been quite helpful. As long as his mother gives him it once a day, he knows he can't touch alcohol for the next 24 hours. And it makes a difference to him. There are therapies that work, but they don't work very quickly. There are lots of therapies, as you know. There are probably as many therapies as there are kinds of psychologists. But there are therapies that do work, and it's worth exploring them. There are medicines you can take that reduce suicide rates. They're not that many, by the way. Antidepressants have not been shown to reduce suicide rates. Isn't that interesting? You'd expect if depression causes a lot of suicide, that antidepressants should reduce suicide rates, but there is no real evidence of this. Lithium, which is a very dangerous mood stabilizer, if you take 3 times your normal dose, you could die by it. Paradoxically, if you take it regularly, it reduces your suicide rate. Some of these things are difficult to understand. Lithium is a hit and run drug like no other. If I could, if I could erect a statue to lithium, I would. And then there's clozapine. If you have schizophrenia, it's the gold standard drug. It reduces suicide rates, but clozapine is not for everyone. Hospitalization is sometimes the most sensible thing to do in someone who's acutely suicidal. Not purely because that's the only way to manage suicidality, but it's sometimes the most effective way to manage it. It buys you time so you can set the other supports up in place. Ketamine is an anesthetic agent that's very old, but has been increasingly used. I've been using it in Manasa for a while. I think for some of my patients, it's been fantastic, but for most of my patients, it's been slightly helpful in reducing suicidality. I would not want to call it a magic drug, although it was thought to be. We're not sure if psilocybin and all the psychedelics will help in suicidality. We're hoping for them to come. Some of you may have already sampled some of it, not from a medical store, but informally. But we're not sure. I think there's a lot of hope that psychedelics will help the suicidal. The evidence is still awaited. ECT is the most effective treatment in the world for severe depression, severe suicidal depression. Within 2 to 3 sessions, somebody who's acutely suicidal will feel no longer suicidal. But it's like the control and alternate delete of the Windows world, or the force quit of the Mac world. If you're an Apple fanboy, then it's force quit. And it seems to have magical responses in suicidality, but it's not for everyone. It's for people whose suicidality is thought to be related to severe depression or another illness. Some of this is for mental health professionals, but once you find someone who's at risk, don't take your eye off them. Make sure there are people around them who keep an eye on them, take them to their appointments, make sure they follow up on all the treatment. Don't do it yourself, just by yourself. Make sure you get friends to do it. Get a group of people around you. That's it. I think I'm just going to repeat the bits that I talked about. When do you refer someone? Now, this is largely for mental health professionals, but when think of your spidey sense. If you're worried, get them to go see someone. Ideally, a good psychiatrist. Try and identify one. Almost certainly, IISc will have counselors. I'm imagining. IISc, like all, I've recently been asked to go and help with National Law School's issues. They had a death recently. But I'm assuming IISc has a counselor on site. The big question for us is, how much support do your counselors get? Just question, are any of you counselors here for IISc? No? Okay. But a lot of our counselors in most universities work single-handedly, and they have to figure out how to help people, when to help people. And one of the jobs that we may have is trying to support counselors doing their difficult work. When you see someone with ideas and plans, they have to go and get specialist help. Don't sit them at home. Don't try and do apple cider vinegar, yoga, headspace. No, they need help. When someone with chest pain goes to hospital and we find they don't have a heart attack, then we don't feel sad about it. We don't say, you wasted my time. We say, we're delighted you're not having a heart attack. It's the same with suicidality, people. If you think somebody is not safe, if they're at risk, please get them help. Maybe they didn't need help that time, but you didn't do them any harm. So please don't sit on it. A very good rule of thumb for doctors is this. If I go home and worry about some patient, I know I need to do more. If I know that if I didn't do enough for that patient, I'll go home and think about them, then I know I just need to do more so that I don't go home and worry about them. So that should be your thumb rule. If there's somebody that you're worrying about, do something that day. Spidey sense. Sometimes your gut instinct is something. I don't know where the gut sits with respect to this. Maybe the microbiome has its own intelligence system. We'll figure this out. So this is my summary. This is all you need to do. It's not rocket science. Pretty simple. Ask Spot. If you worry about someone, ask the question, what is the worst thing that can happen? Buy them a coffee or a tea if you want. But ask the question, do the right thing. If you don't know where your local IISc counselor is, go and make friends with them. Say, look, I went to this guy, he talked about it, he wanted me to find out who you were. And don't be afraid of your counselor. They're usually very sensible, kind psychologists, and they're desperate to help you because that's what they're employed to do. That was it. And if you have any questions, I'd be happy to take them, but I'll pass you back up to Dr. Kalyan. Before I forget, please scan that thing. If this is really rubbish, you please blame Dr. Kalyan. But otherwise, please tell us what you think, because I'm really keen to assess at least whether or not you felt this had any relevance to your life, because I'm very convinced that we can actually do this with people who are just interested, don't have to have any medical training at all. I might be wrong, but we will try and evaluate at least this acceptability part just now with this. Thank you.
Thank you, Professor Srinivasan and the team for having this topic discussed during the first suicide month this week. You're probably aware by now that it's a huge topic. I mean, it is not possible to cover the various facets about this difficult condition and give you tips that you can all manage in your environment. But I agree that Dr. Aditya is on clear ways of communicating. I'll give you some ideas to think about. When you go back home, walking back, sitting, having dinner, something will resonate in you. For sure. I knew somebody who had something like this. I only wish I had gone ahead and sat with that person. I only wish I'd allowed the individual to open up. Because we are surrounded by people who are desperate for seeking help, but they do not know how to go about asking for such help. They do not know whom to ask. This issue of stigma, that I wanted to keep it hush hush. It's a major concern among professionals. I never fail to say what is it, be in my bonnet. You'll all see that several new, what I call corporate hospitals open up, and they will advertise in the newspapers and sometimes in other media, but what are all the specialties that are available in that particular specialist hospital, including a doctor with the left ear, a doctor with the right ear, and then right nostril and the left nostril. But you have ever seen anybody mentioning our center also has mental health specialists? Zero. Have you ever seen anybody advertising in the front of the hospital building with beautiful lights, psychiatry available inside? No. There's a huge advertisement yesterday and today, post-event, 3 states, Telangana, Andhra Pradesh, and Hyderabad, Karnataka, a brand new hospital, 300 beds, super specialties, every possible new technology is available. I scanned through very carefully. Is psychiatry mentioned? No. Why are we shying away about talking about mental health? At least availability of mental health in a hospital. Much less about an issue like this. So I think I'll leave it right here. We'll come back towards the end. I have about 10 minutes more, 10, 15 minutes? Yes. Yeah, so let me now ask a lot of young, bright people here and very senior professors. Feel free to ask. I always tell people, don't hesitate to ask a question. What will somebody else think? Could you care about what somebody else should think? You have a doubt, you ask. So let us restrict to the topic of suicide, and anything you want to ask, Dr. Aditya will be more than happy to come to your rescue and respond to your questions. Dr. Aditya, and anybody please raise your hand. I would be happy if you mention your name and mention you're a student here, or a research scholar, or a faculty, just to get the idea behind your question. Anybody? I've been a teacher for 5 decades. All my students know if they don't ask questions, if you don't volunteer, I tell them, I will make you a volunteer. All my students will duck their heads, but I know them even in the nuggets. So, anybody, because I do not believe in this audience. There is no doubt about something related to this. Doesn't matter what it is. Please feel free to ask. Yes, sir.
Does all depression lead to suicidal tendency, or can it be prevented at that earlier stages?
Excellent.
No, not all suicide, not all depression is associated with suicidality. But the more severe the depression, the more likely that you are going to encounter it. Now, it could be active suicidality, or it could be passive or more dangerous suicidality. For example, day before yesterday, we admitted a patient who was not saying she was actively suicidal, but had stopped eating and drinking. And in that way, had become in danger. So suicidality, the more severe the depression, the more likely that you are to see it. The more distress you see in depression, the more likely you are to see suicidality. And that for us is a flag that says, okay, this is not just something that people have to wait and do whatever. Sometimes the presence of suicidality will change the decisions I make with respect to that treatment. But a lot of mild depressions are never picked up. Most people's mild depressions are not even diagnosed. If I have a mild depression, say 2 weeks of feeling a bit sad and low, whatever, I might miss it completely. So it's very hard to know what the prevalence of mild depression, mild to moderate depression is. But a lot of people go through depression with no active suicidal thoughts. There will be passive suicidal thoughts. But the moment you see suicidal thoughts, for us, it's a flag that we know that we can't just sit on it, that that person needs more help than just waiting or yoga or pranayama or something else, because we know then there is danger. Thank you.
I wish I could die is different from I want to die. There's a qualitative difference, but there is a significant difference. One can translate from one level to another. Because you are all dealing with young colleagues of yours, and Dr. Aditya very clearly said about somebody is isolating oneself, not wanting to meet people, and not wanting to respond to you when you want to talk about it. That's something what they consider personal, then you'll find they don't want to be with you next coffee break. These are signs one cannot ignore. I want to ask you something, Aditya. I'm sure you will come across people. Patients will come and tell you they've come alone and they're not coming with any family member. They say, doctor, I want to tell you, I hope everything is confidential. We assure them that yes, of course it is confidential. We also talk to you about this confidentiality about suicidal thoughts. Please don't share this with my family members. What do we deal with that?
Well, if you haven't met the patient before, but for those of my students who will become therapists or colleagues who become therapists, I've always warned them that you should advise your patient of the limits of confidentiality, which is it is not sacrosanct. A lot of therapists mistake the therapy space for the confessional. It is not. And we should be saying to patients, people who come to us, I will protect your confidentiality to a very great detail. The only two circumstances in which I cannot or I will not is if you're saying to me that your life is in danger or someone else's life is in danger, then I may have to go outside of this space. That's something that you should set up early on. But sometimes you've never met a patient before who says, I want to tell you something in confidence, and they will tell you. Now, when I was younger, I would think that confidence is more important than anything else, but I realized that's wrong. What matters more is that our patient remains alive, that they may not be a patient, they may just be another person, but that you have a chance to help that person. It is really important that you spend time convincing them that actually the more people who can be involved, the better. When you're really depressed and suicidal, you may feel that no one cares, that you're alone, that there is no hope for the future, and that actually you have become, and one of the red flags for suicidality for us is when someone says, I have become a burden on my family. That's a really scary thing for me to hear. That's when I realized that people say, actually, my death will be a favor, a positive action that will help my family, because I have become such a burden that my going, it's what Durkheim used to call the altruistic suicide, that my going actually will benefit my family. And that's a function of depression. It changes how you see yourself, your life, and yourself within it. And it's very important that you try to convince the patient. And actually, I'm very comfortable reaching the patient's confidence on that front. And when a patient is saying to me, I'm thinking of this and I'm actually going to do this and I don't want you to talk about it, I will do my best. And if I don't get consent, sometimes I will breach the confidentiality, explain to the patient. I've never had a patient so far who's angry with me to the point that they will not work with me after that. Most people understand. Most families, when you explain it properly, will get over this initial thing of it's just attention seeking. So they're just saying something. This belief that, people who say something about suicidality, there is a common misconception that people who die by suicide never talk about it. Most people who die by suicide will have left clues in their conversations or whatever. Most of us in our families don't want to hear it. I have heard family members say, hey, don't be silly, don't say such things. Promise me you'll never say such a thing. I went and did a talk in a college recently, there were 200 people. And they said, we are now in our therapy services using a contract. What's the contract? I will not die by suicide while I'm working with this therapist. I was sitting there thinking, what? I see the rationale of it, but the belief that, this stuff is under your voluntary control and your poor patient will stay alive just so that you don't get into trouble is a misunderstanding of the nature of the problem itself. So we need to work with these people. We may need to breach their confidentiality. And if we do that, then we have to take care. You don't do it casually, but there are ways of doing it that will help.
There are other issues which I want to bring into your attention. The sense of loyalty between peers and friends. I'm sharing with you something very, very close to me, but you're my best friend. I want to tell you this is the kind of problem we've been facing. The interpersonal problem with my relationship, with my partner, with my parents, finance, and I think I'm desperate. I don't think it is worth living. But promise me, you will not tell a soul. You're torn between what you have heard and the promise. Sometimes, unfortunately, the loyalty fact takes precedence over common sense, sensible thing to do. While speaking and mention of it, we have had patients who come to us as patients ridden with guilt about the fact that I had not shared this with her right kind of thing. I did not persuade him or her to go and see. The person, the girl or boy's family is very known to me. I go to the houses frequently, but I could not tell the father or brother. And they come with a guilt feeling utterly miserable that I've let a soul go away. Because this is something which youngsters must understand. Loyalty is one thing, life is something else altogether. You may be the only person who has seen this or heard of this. Yet, and this is very critical. Lord Aditya, I just want to flag one issue which is very common today with youngsters, the impact of social media. And I've had patients, one of the very patients I had were actually had this issue was about 10, 12 years ago. A young girl who had a relationship with a boy and then they fell out. And the boy writes in the social media, what a great time we had last 1 week. I'm sure all your friends don't know about it. I don't think any great thing happened, but to take revenge. And the girl hung herself. So the social media, and from then to now, they say so many grams, Instagram and other things. I don't much understand these things. Youngsters know better. It's all about what you do. It's all about what you do, what you want others to know. But it has a very negative impact also. So what I like to say about how do we, how do youngsters to be careful about the social media impact, which can impact them negatively, and extreme steps may be taken tangibly too late.
Thank you, sir. I think there's good evidence that the more social media you use, the more unhappy you are. There's very good evidence to say that consumption of social media is directly proportional to unhappiness and negative emotions, which is easier said than fixed, because most of us have very high screen utilization times. The social media are designed to keep us really actively involved, our eyeballs actively involved. Not only, so the average person with no depression will have trouble the more social media we use. It doesn't matter what kind of social media you use, but particularly the kind of the grams that Dr. K.S. was talking about, Instagram, particularly if you're looking for likes, acknowledgements, engagement, then you're in trouble. If you're feeling depressed, you're much more likely to feel other people are having a more positive time than you are. Because most people on social media go to tell you what wonderful meal they had, how lovely their holiday was, how they're living their best lives, and all that sort of stuff. And all of that has been proven. So what's very interesting is, in the old days, my grandmother would say that you shouldn't talk about really happy things because you will attract negative attention. In Kannada, they say Drishti. I don't believe in Drishti, but what is very clearly, my grandmother was right in one respect, in that there is good evidence that when you put your most positive experiences online, it causes pain in others, including your very close friends. Remember this, that there is a perverse thing. They will say they like it, and if you're a girl, they'll say how fabulous you are, whatever, and if you're a boy, they'll say something else. Doesn't matter, the word's different, and whatever gender you are. But you are inviting some amount of negative emotion. We know that it is bad for your body image, that if you use social media beyond a certain amount, it does make you feel a bit less attractive than your average peers. We also know that it increases your suicidality. The American Army, interestingly, the armed forces did a really fantastic content analysis thing, which said they could spot suicidal thoughts in people well before the people themselves recognize this. This is 20 years old, this kind of data mining. It's fantastic. But because it was such a hue and cry in the public, that disappeared. I'm hoping it will come back. Facebook already knows to have certain algorithms that will warn you that if you're feeling low, they will spot you. But we think there is a lot more data in Instagram and stuff than they share. But please be aware that if you're feeling crap, don't go on social media. Try and take a digital holiday. Take a real holiday. Go somewhere and try and make some friends that you can meet. 5,000 followers are not friends. Facebook's definition of friends is really perverse. These are not your friends. You can have 5,000 friends. Not one of them will cross the road to help you. Most of them won't even recognize you. So this idea that social media will make you more connected has been a fantasy that has not proven to be true.
Thank you very much, Aditya. I entirely agree. When you say your grandmother, which is the generation of my parents, they have told us, it was very clearly indicated that you don't talk about achievement of children. You don't tell relatives and friends, hey, you came first, you got a gold medal. That's not done thing. That's not a done thing. You have it, you just today you advertise every little quote unquote achievement to the public, known and unknown. I think we can go on and on and on. I think Dr. Paramesh is clearly indicating you're crossing the time. Thank you very much on behalf of both Dr. Aditya and myself. Excellent opportunity, and next time we wish if there's an opportunity, the youngsters will open up a lot more than they're thinking. We're going to walk back to the hostel or have tea, a snack. They'll think about it and make sure every one of you will help somebody down the line. Aditya, go.
Thank you all. Pleasure to be here. And please do your very keen to find out what is really not be nice. Thank you, sir.
Okay, a wonderful talk, wonderful conclusion. We thoroughly enjoyed it. And also it makes us to go home with a positive thinking always. And also I like to reveal here, ICMR He's trying to find out in rural area, because of the global warming, climate change, what is the stress situation, mental health. NIMHANS has taken it over. We are the coordinator with that. So Indian Institute of Science, NIMHANS, and they have selected 4 taluks in India. I think one of the taluk is in Karnataka, that is in Tirthalli. So we are working on that one. Then we like to publish whatever it's within NIMHANS, Indian Institute of Science will publish it. Thank you very much again. And as a
3 years ago, when we had the same topic, that was a COVID
yes,
period, and it was online. And I was on the chair, and Dr. Shekhar Seshadri was a speaker. And I
yes.
think I'm coming to warm the chair literally this time in this building of this chambers.
Yeah, during that time I interacted with Shekhar Seshadri because I was in charge of H1N1 control. Yes, Anand in COVID, H1N1 earlier. And also as a token of appreciation, please accept a small memento. I request Professor Srinivasan to hand it over. And all of you will have a photo together.
All of you don't. Please come.
Even people in Europe cannot come.